My name is Mike Miedema. I'm the Director of Cardiovascular Prevention for the Minneapolis Heart Institute. And by all the raise of hands I saw earlier, clearly we have a lot of work to do. So we have a long way to go to try and eradicate heart disease. And I also like to point out that I think I'm at a disadvantage here because I missed the memo that you're supposed to have a charming accent to present tonight. And so I'm already starting behind. Plus I have to tell you to eat your vegetables and take your statin. So I feel like I'm at a significant disadvantage. So we're going to talk in 10 minutes about cardiovascular prevention. And the nice thing about this is that it's very generalizable. This applies to everyone in the room for the most part. So I hope you'll find it of some value. So we're going to cover three things relatively briefly. We're going to talk about diet and exercise, and then we'll talk about your cardiovascular medications that can help reduce your risk, and then we'll end with a patient case. And so when we talk about diet, sometimes in science, you don't have to be right, you just have to be first. And kind of the first concept when it came to diet and cardiovascular disease is that when we eat saturated fat, our cholesterol goes up, and when our cholesterol goes up, we get coronary heart disease. And the impetus for this came from some basic science studies as well as something called the 7-country study. And this was done by Ansel Keys, who was actually at the University of Minnesota at the time in the late 70s. And he took data from 7 countries and looked at their saturated fat intake and looked at their rate of coronary heart disease. And what he showed was that as the intake of saturated fat went up, the risk of coronary heart disease went up. Now, they had data from 22 countries overall, and how these 7 countries were selected is a little bit controversial, but this raised the concept that eating more saturated fat causes heart disease. And because those plaques, if you look at them under the microscope, they kind of look like they're full of cholesterol and saturated fat, it made sense, it was intuitive, and so we kind of ran with it. This study really should have just been hypothesis generating. It should have raised the question that maybe this is true. Instead, we kind of accepted it as true. When you look closer at the data, it gets a little bit more confusing. And so when you take in saturated fat, your cholesterol does go up. That's very clear. This is a study looking at which type of fat you take in and what happens to your bad cholesterol. And as your saturated fat intake increases, your bad cholesterol goes up. Conversely, as you take in healthy fats, these are monounsaturated and polyunsaturated fats, your bad cholesterol goes down. So again, raising concern that saturated fat is bad for you. However, if you look at the relationship between good cholesterol and coronary heart disease, as you take in saturated fat, your good cholesterol goes up the most. And we know one of the more important predictors for lipids is your total to good cholesterol ratio. And so if you look at your ratio as you take in saturated fat, it stays relatively neutral. And so saturated fat does raise your bad cholesterol, but it also raises your good cholesterol. And so in the subsequent studies, when they look at big cohorts of people, the people that eat more fat, including saturated fat, don't seem to have more heart disease. This is data from the Nurses' Health Study. So this is over 77,000 women, and they put them into fifths according to how much fat they were taking in, and followed them for over a decade. This is actually over 20 years of follow-up. And so this is their risk of having a heart attack, and if you'd expect it to kind of slowly creep up as they take in more saturated fat, but instead, it was relatively neutral. The people eating more fat in their diet didn't seem to have more heart disease. And so one of the issues with nutritional research is that you can't compare it to a placebo. You have to eat something else. And so most studies comparing a certain diet to the Western diet look great, because our Western diet isn't very good. But when you start comparing healthy things to healthy things, it gets a little more complicated. And so this is a study looking at if saturated fat goes out, what goes in? And so for the people that took saturated fat out of their diet and replaced it with polyunsaturated fats, so this would be eating less butter and eating more olive oil, these people had less heart disease over time. Their risk went down. Whereas the people that replaced their saturated fat with carbohydrates, the risk actually went up. And if you take these carbohydrates and you break them down into different types of carbohydrates, the people that took fat out of their diet and replaced it with whole grains seemed to reduce their risk, whereas the people that took fat out of their diet and replaced it with sugar drastically increased their risk. And we've been doing this for decades. And so this is low-fat yogurt, this is low-fat ice cream, a lot of low-fat dairy products, you take out the fat and you put in sugar. And that's clearly an unhealthy substitution. So if fat goes out, something else has to go in. That's the main issue. And so we have a large trial looking at a low-fat dietary pattern to try and prevent cardiovascular disease. So this is the Women's Health Initiative in the 1990s. They took over 40,000 women, and for 10 years straight, they had half of them eat the lowest fat diet they could eat. They were told to avoid fat, and at all costs avoid saturated fat. And after 10 years, compared to the people who were eating a fair amount of fat in their diet, they didn't have one less heart attack or one less stroke. They didn't seem to have any better cardiovascular outcomes. It didn't seem to improve their health to avoid fat in their diet. Conversely, we have recently what's called the PREDIMED study, which was a study looking at including healthy fats in people's diets. And so this was people who got a quart of olive oil a week, and half of them got a big jar of nuts and seeds, so basically a lot of poly and monounsaturated fats. And for the first time, we had a dietary study where the people that took in more fat had less heart disease over time. They had less cardiovascular disease. They had about a 25% reduction in the risk of heart attack and stroke over the 3 or 4 years of the study. This is the only randomized trial we have for diet that seemed to improve outcomes. And so people who take in more healthy fats seem to do better overall. And so the simplest way I can break it down from a diet standpoint is that people will say, I'm in the grocery store and I'm looking at ingredient lists, what should I find or what should I avoid? And my answer to that is that the vast majority of things you get at a grocery store shouldn't have an ingredient list. They should be a single ingredient. And so if you're getting fruits and vegetables and salmon and maybe a little bit of steak and olive oil and milk, you're doing well. If your things are coming out of a package or a box or the drive-thru, you're probably going to be in trouble. Moving on to physical activity, there's only one slide for this part of the talk, because it's very, very simple. This is a meta-analysis, meaning kind of a look at all the trials that are available on how active you are and your subsequent risk for cardiovascular disease. And this red line here is what the risk happens as you are more active. And it goes down and it keeps going down. They have these lines here of 150 minutes a week or 300 minutes a week, but in reality, doing some helps, doing more is even better. And the nice thing about the research is that it doesn't seem to matter what you do. So whether it's walking or jogging or swimming or hiking or yoga, it's all good. So do whatever you can and do as much of it as you can. It's all beneficial. And then for the second part, talking about medications, there's lots of studies on statins. There's lots of studies on different blood pressure pills. We now have some new diabetes medications, which look really promising. Instead of going through all those trials, we're going to try and get at the why. Why is it important to take these medications after you've had a cardiovascular event? And if we look at these studies, some of these concepts go back a long ways. Some of these concepts have been there for a while. We just haven't paid as much attention to them as we probably should have. And so if we go back to the beginning of cardiology research, that's really the Framingham Heart Study. And so in the late 50s and early 60s, we really didn't know what caused heart disease. And so they went to Framingham, Massachusetts. They gathered together about 6,000 people. And they followed them for 5 years. And they looked at who had heart attacks and who didn't, and looked at the risk factors for having heart attacks. And the take-home point from that study was very clearly that cardiovascular disease is a multifactorial process. It's not just one thing that causes plaques to build up. It's lots of different things. So in the initial publication, it was your blood pressure plus your cholesterol, plus actually LVH on an EKG if your heart was a little bit thick. But over time, it became diabetes and smoking, and then we figured out stress and dietary components and exercise or lack of physical activity. There's lots of different things that factor in to having plaque buildup. If you're going to assess somebody's risk for a heart attack, you can't just look at one risk factor. We were talking earlier, if you look at our heart attack database at Abbott, for the people coming in with big heart attacks, the average cholesterol in that group is pretty average. And that's because if you're a 65-year-old male smoker with diabetes and gorgeous cholesterol numbers, you're high risk. You can't just look at one risk factor to assess somebody's level of risk. And the second component is that when you're looking at that one risk factor, if you just look at that, you're going to miss a lot of individuals because it's a multifactorial disease. And so this concept was raised in the early 80s by this epidemiologist, Jeffrey Rose, and it's called the prevention paradox. And the prevention paradox is based on the concept that for a lot of risk factors, if you just use that risk factor, you're going to miss the majority of diseases. And one of the examples they used was coronary heart disease. And so this is data from a big cohort in the 1970s. And these black bars here are the distribution of cholesterol levels throughout that group. So pretty normal distribution. This is a total cholesterol of around 200, so pretty average for the population. And then these white boxes here are the rates of coronary heart disease death according to those people with those cholesterol numbers. And what you'll see is these white boxes are a little bit skewed here out to the right. They're a little bit higher here than they are here. And that's because people who have higher cholesterol have higher risk for having heart disease. It's clearly a risk factor. However, if you were in charge of the US population and you said, above a total cholesterol of 270, these are the really high-risk people, we're going to treat these people and we're going to get rid of heart disease in the US. That is going to fail miserably because the vast majority of deaths from heart disease occur in people with relatively normal cholesterol levels because that's where the vast majority of the population is. And so again, just focusing on one risk factor doesn't help us capture the population at risk. And then the final concept, which is probably the most important one, is that if you look at the relationship between cholesterol and heart disease, it's very clearly a linear relationship. And what that means is that as your bad cholesterol goes up, your risk goes up. And as it goes down, your risk goes down. And there's no magical thresholds here. And so in the trials, what we've seen is that the people with high cholesterol that lower it seem to have less heart attacks and strokes. But the people with normal cholesterol that lower it seem to have less heart attacks and strokes. And even more recently, the people with low cholesterol that lower it further seem to have less heart attacks and strokes. And we can't seem to find that bottom cutoff. The lower, the better. The lower your cholesterol goes, the lower you are at risk for heart attack and stroke. And that's exactly what we've seen in these statin trials, is that the people that take a statin and their cholesterol goes down, their risk goes down, regardless of where they start. And so the take home from that, if you look at the most recent cholesterol guidelines, is that when you're making the decision to start the statin, it's not about your cholesterol numbers. It's about your level of risk. And the first thing the guidelines say is that if you've had a prior event, you're at enough risk for another event, you should take a statin, almost regardless of where your cholesterol's at. And so it's not about your numbers, it's about your level of risk. And so some of the recent trials have really kind of gotten at that. And so this was a trial from 10 or 15 years ago where to get in the trial, you had to be a middle-aged individual with high blood pressure. And so because you have higher blood pressure, you're at enough risk where you might want to think about lowering your cholesterol. And these were people with normal cholesterol levels to begin with. And they actually had to stop the trial early because they had a 36% reduction in heart attack and stroke and death from heart disease over the 3 years of the study. And so this isn't super intuitive for our patients. You know, Mr. Jones, your blood pressure's high, therefore I want to lower your cholesterol. They're like, that doesn't make any sense. Well, it does if you think about it in terms of risk. You don't feel your blood pressure, you don't feel your cholesterol, you feel the heart attack or the stroke. That's what we're trying to avoid. And then another trial looked at people with diabetes. In order to get in the trial, you had to be diabetic, and because you were diabetic, you were at enough risk where taking the statin made sense. And so, the next question that immediately is going to come up is that, well, what about the side effects? Because I don't want to feel poorly on the medication. And this is where it gets really tricky. One of the issues we face is that with these medications, there are lots of reports. There's lots of anecdotal evidence of, well, my aunt took that and she was in a nursing home a week later. And my uncle took that and he died a month later. Are we sure it's not the medication? There's lots of anecdotal evidence out there that these medications might be bad for us. And part of that comes from some partial truths. Baycol was one of the first statins, and it came out mid-90s, and it was a bad drug. It had some metabolism issues, and that led to some muscle breakdown, which then harmed the kidneys, and so some serious issues, especially for preventive medication. However, that medication's been off the market for 30 years now, and the more recent ones seem to have pretty good safety data. And so if you go on the internet right now, and you type in, should I take a statin, you'll immediately read, don't ever take a statin, you'll be dead within a week. It's a terrible idea, never take these medications. And so again, some of these partial truths and a lot of these anecdotal evidence, it can be a little bit misleading. If we go back to these trials though, we see some things that are a little bit different. And so this is Jupiter, which is one of the bigger statin trials that we have. And in the trials, they're forced to report, or they have to report adverse events. And these are blinded trials. So half the people are on a statin, half the people are on a sugar pill. Nobody knows which one they're getting. And so in the trials, it's been pretty consistent. The number of adverse events reported if you were on the medication was roughly 15%. 15% said, I got something going on, I'm worried about being the statin. In the sugar pill group, it was 15%. And this has been incredibly consistent. We're at a point, I think, about 37 trials and over 200,000 patients, and the reported rate of side effects is exactly the same between the statin and the placebo. And so when there's a trial looking at it, kind of lumped these all together, the rate of side effects, like I said, was pretty much identical between the groups. There was no evidence of any significant toxicity to the point where it's been raised, maybe these should be over the counter. And so I don't think that's going to happen anytime soon, but the safety data is really good. If you look at blood pressure, it's pretty much the exact same concept as the cholesterol. There's a recent trial looking at getting people's blood pressure down to just under 140 versus down to around 120. And they actually had to stop the trial early because the people who had lower blood pressure over time had less heart attacks and strokes. And if you look at the relationship between blood pressure and risk for heart disease, it's again pretty linear. As it goes up, your risk goes up. As it goes down, your risk goes down. There's nothing magical about 140 over 90. And so if you look at this is a subgroup analysis, not to be too nerdy about it, but basically looking at the benefit of the intervention, the people that started the trial with a blood pressure of around 130 had the same exact benefit who started around 140. Wherever your blood pressure is, lowering it made sense. It lowers your risk. And so we have really good evidence that if you've had a cardiac event, the people that lower their blood pressure and lower their cholesterol are clearly at lower risk for future events. And so we're going to end with some anecdotal evidence of our own here, except this is positive anecdotal evidence. This is a good story. And so this was one that was recently published in New England. It's a guy I do research with out in Boston, and it's a pretty cool story. It's a 42-year-old gentleman who had high cholesterol, and he had a family history of heart disease. In the last 4 months, he has 2 flights of stairs at work, and when he goes up the second flight of stairs, he'd get a weight on his chest. It seemed to be getting worse. And so he went to see his doctor. They said he should probably get a stress test. So they sent him up for the stress test, and you don't need to be a cardiologist to read this. These are the stress pictures, and there's a bite missing from this part of the donut right here. And if you look at the rest picture, it looks pretty normal. that suggests that there's a blockage in this part of the heart, in the artery that feeds that part of the heart. And so they said, your stress test is positive, you may need an angiogram. He said, boy, I really don't want anything invasive. So they went to a CT scan instead. And so we got the CT scan, and these are the coronary arteries right here coming out of the aorta. And it's the same heart, it's just at a different angle here. And right here, there should be this contrast like this. It should be kind of white in this area. Instead, it's all gunked up with plaque. And this artery right here feeds that part of the heart that we saw in the stress test. This fit together well. They said, yep, you've got a blockage in that artery. We confirmed it with a CT. We should do an angiogram, and you should probably get a stent. And he said, boy, I really don't want anything invasive. Is there any way we could treat this medically? They said, well, we can try, but we'll see how it goes. And if you get better, great. But you're really going to have to do a good job with the risk factor control. And so he went on a statin. He also took another cholesterol pill called ezetimibe. He went and saw the dietitian and worked on changing his diet. He joined cardiac rehab and slowly worked on increasing his physical activity. And over the next 3 months, his symptoms went away. And he felt better. And so they treated him medically. And about 3 years later, he came back in, and he had a little zing of chest pain. He said, boy, didn't feel anything like what I had before, but it made me a little worried. And so they repeated his testing. And his stress test is now completely normal. He didn't seem to have any defect. And so they repeated his CT scan, and that artery is now wide open. All of that gunky plaque that had been there had dissolved. As you lower your bad cholesterol, as you lower your blood pressure, as you exercise more, as you eat better, that plaque can regress. It doesn't always regress, and you don't have to regress it, you just need to keep it stable. And all those things can help keep it more stable. And so yeah, there's the before, and here's the after, and he had a lot of regression of a lot of this soft plaque. So that's our positive anecdotal evidence for today. Thank you.